We're still at a stage where we need to continue to collect all the data because we don't really know when it's all said and done.
So when we're talking about PRP, I think there's been a lot of conversation about trying to characterize it. And I think we're still kind of currently talking about, oh, this leukocyte-rich versus leukocyte-poor. Do you think that there is a more nuanced way to think about it? Is there should we be talking about it differently? What are your thoughts on that kind of discussion of classifying it in these two different camps?
Yeah, I still think in this discipline, we're still at a stage where we need to continue to collect all the data because we don't really know when it's all said and done what the magic numbers and what the magic characterization is going to be to match and correlate with clinical outcomes. Now, there's the obvious things, leukocyte-rich, you've already named, leukocyte-rich, leukocyte-poor.
Don't forget, if you want more about the business of orthobiologics, I have a podcast, or you can go on my website, The Business of Orthobiologics, and tune in.
I like adding a leukocyte-neutral category. There's other things.
Can you explain that a little bit? And there may be people on this call that don't really understand how you can have a leukocyte neutral. Like, what does that mean?
So traditionally, in years past, leukocyte-rich PRP typically referred to PRP where the white blood cell count was north of in the 20s, 25, 35, somewhere in that range. And when you got into WBC counts that were that high, a lot of us noticed that patients seem to have more trouble with pain and discomfort around the time of the procedure. Their outcomes may be the same. In fact, a lot of recent data is showing that their ultimate outcomes may match even leukocyte-poor, but the issue was around the time of the injection for some of us. But that's with a white blood cell count well above the upper limit of normal human WBC count, which is maybe, we'll call it 10 or 11, okay, on a typical hematology machine. Leukocyte-neutral, what I call leukocyte-neutral, and I don't think I'm the first, would be a clinical example where I get a CBC on a patient, their white blood cell count is 5, which is well within the normal range. We make the PRP, and their white blood cell count in the PRP comes back at 7 or 8. It's a little bit higher than 5, but it's still within the normal human range up to 11. So I tend to call that leukocyte-neutral because at that level, it doesn't seem to create any flare, even though if you're going by the strict semantic criteria of is this number higher than that number, sure, 7's more than 5, but 7 is still within the normal human range. So that's what I would consider leukocyte-neutral. Leukocyte-poor would just be starting at 5, and in your PRP, you're less than where you started.
Now, here's the more burning question is, should we be talking and should we be thinking about which leukocytes? Is that too broad of a category?
At this stage, it is. I mean, it's going to take, honestly, probably a lot of computing power to correlate specific leukocytes. And, you get into even things like eosinophils and basophils and all the things we used to learn in hematology class to try and correlate that to clinical outcome. Right now, I think the best thing we have that's kind of easiest to access would be the platelet number and the platelet dose. It's easier to structure clinical outcome studies around platelet dosing right now. And of course you can correlate leukocyte content, but even with that, we can still see variations in outcome and variations in outcomes amongst different researchers. So I think it's going to take organizations like the Biologic Association, which has their tremendous BARB repository project, where they're storing and quantifying basically anything you can quantify coming out of blood. And then at some point, that's going to go into a big supercomputer, in my mind, and some AI is going to figure out the charts and the graphs and see if they can do a regression and figure out what's correlated to what.
Don't miss out. Please subscribe to our newsletter now to stay ahead of the world of orthobiologics. You can find the link below.